Any questions for me? Where did we stop? Had we finished the finished? Okay, so we're so guys, this chapter 24, I guess is the number of it. Chapter numbers, but anyway, so it's this chapter. This chapter really has a lot of repeat things from what we've had in the past. Some things about the hormones, which I know never hurts to get that reinforcement. But there's also a few little things we'll hit on. So let's go with this, and then we'll go ahead and start with the digestive system. You know your next test in this class is going to be urinary indigestion, right? And honestly, let's go ahead and set a date on that. Let's set a date on that. That date on that test, that next test, would be, well, do y'all hate Monday tests? They're bad either way, Sarah.
It doesn't matter.
So anyway,
Yeah, I just like Mondays better.
okay, all right, well, listen, so I just think it probably needs to be, because we're going to finish this stuff up. So, look, so it will be on Monday, the Monday 2 weeks from today. It will be, it's the 15th. So,
Yeah, 2 weeks.
yeah, so the 8th and the 15th. So, okay, so April 15th, tax day, y'all will have a test on urinary and digestive systems with those 2 chapters that kind of go along with it too. So it's really 4 chapters. Make sure you remember insights, disorders, my lecture notes, and anything about any hormone. Yes, we do look it up. Just come in. Just come in on 8 o'clock. Okay, all right. Oh, awesome. Awesome. We'll work it out.
Okay.
So guys, and then we said that the last test in this class, I've already told you all, that will be a take-home test on the reproductive system, right? All right. So, but this test is not. So if you did not do well on the lecture quiz today, catch up. Catch up the day before, because you have 2 weeks. And we have a lot more information to cover that will be on this. All right, so let's go ahead and continue with our notes today on this. Water, electrolyte, acid-base balance. So I hope you're already seeing from the title, these are a lot of topics we've already talked about. Acid-base balance referring to what? pH. And so we know that the 2 major organ systems that control pH are the respiratory system and the urinary system. They both are major players in controlling pH in the body, major buffering. Hey, so we get that door, thank you. So when we think about water in the body and how water is moving between compartments, and they're talking about an average sized male, I guess, you know, we've got a lot of water and our cells. We've got trillions of cells, but our cells are filled with water, aren't they? And that's the cytoplasm of the cell, and in that cytoplasm of the cell, there's all our organelles and all of those molecules that we said that are carrying out functions for the cell. But then cells are all bathed in fluid too. So the extracellular, intracellular fluid, extracellular fluid, and you can see where some of this extracellular fluid is. So I do think it, you know, it's kind of common sense that since you are made of all your cells, that most of the fluid is inside is intracellular fluid. Now, how do we know water moves and why does it move? The movement of water. We said that water will always move how in relationship to its gradient. Is there any way the body has a mechanism of moving it against its gradient? No. That's very different than solids, because inside of our cell we have these pumps that are working because we make ATP and it causes them to work, and we can push solids against their gradient from low to high. But we can't do that with water. So how water is moving in the system, we have to understand something called osmolarity. And a balance of osmolarity between compartments is going to be vital for some of these compartments. But think about this. So you're drinking liquids, and most of what we drink is water, you know, even though it's flavored a lot of times. But it's water, and even our food has water in it, doesn't it? So from our GI tract, gastrointestinal tract, water, because it's in high concentrations here, will move into the bloodstream. But we said in the bloodstream, what do we call the liquid part? We called it what? Plasma, which is mostly made of what? And we said that water will then move into our tissue spaces and the extracellular fluid, and then it will move into our cells and out of our cells. And that water that's bathing our fluid, what did we call it? Our tissues, what did we call it? We called it lymph, the water that's bathing our cells and our tissues. We called it lymph, and we said lymph gets sent through a vascular system, the lymphatic vascular system, and eventually gets returned back to where? Bloodstream. So y'all already knew this, didn't you? But maybe this is a good visual for you to be thinking about how water is flowing and how it's moving, and how with water moving is also moving some of the solutes, and certainly electrolytes playing a huge role. What major electrolyte do we know influences where water is going to go? Sodium. What's the major extracellular cation, positively charged ion? Extracellular is sodium. Intracellular is potassium, but extracellular is sodium. So sodium is playing a major role in how this water moves. We certainly take in water through food and drink, but we also we actually can make water, and you all know that too because of that aerobic respiration formula that I had to learn in the first couple of weeks of AMP1. What were the reactants in aerobic respiration? What are the reactants? Go ahead and say it, Dakota. You know it. C6H12O6, which is what? Glucose plus what? No, it's the reaction. 6O2 oxygen. So glucose and oxygen. If we've got glucose and oxygen in our system, and they can enter into our cells, what can our cells make a ton of? Well, they will, that's an end product, but what will our cells be able to make? ATP. That was the arrow. I said in any chemical equation, the real story lies in the where? In the arrow, right? And in that arrow, C6H12O6 plus 6O2, y'all need to remember this equation. They're the reactants. If we can bring them into our cells, we can make a ton of ATP, Pam. But what will be given off as waste? And y'all have to think about these as waste products. What are the end products? What will be the end products? Would you say? Carbon dioxide and water. Carbon dioxide and water. So we know that we do make metabolic water. So we're making it and we're bringing it in. When we think about water loss, I think you all know we lose water through urine. We said our kidneys is helping to regulate that water balance, isn't it? And it's hard to think about the water in your urine as being a waste product, but it is. We also get rid of it through feces. Every time we breathe out, are we breathing out H2O? We are. If you don't believe it, put your hand over your mouth and breathe out. And what will your hand feel like? Moist, right? So we're breathing out that sweat. So we're getting rid of water in these ways. When we think about this and look at this balance, and I'm not going to ask you specific numbers, am I? But pretty much you should sort of know that as far as an adult, about 2.5 liters a day, we're thinking about intake, and then should the output be the same? How many of my nurses have ever had to do intake and output? Measuring everything of a patient. It's probably one of the most onerous jobs that you have, isn't it? Is to make sure that you are measuring everything a person's putting in their mouth and doing, and then also measuring what's coming out. So, it can be kind of difficult to do, but when people are having a difficult time moving water through the system, for whatever reasons, then you're going to have to be really careful with them. If their kidneys aren't functioning, you're going to have to limit their fluid intake, aren't you? And, anybody who's beginning with kidney disease, they're always in a state of thirst. It would be kind of a horrific way to live, is that you are always thirsty. But that's what's happening with people's kidneys water going. So anyway, just to give you guys an idea, we had said at least 1.5 to 2 liters of urine a day, and it would totally depend on the intake, but output should match it because we want to keep it balanced. What is dehydration? You all, this is something kind of basic. You should be able to intuitively kind of realize this. Dehydration means that the blood volume is down. That means blood pressure would be down, right? Because if the volume inside your vessels goes down, that means the pressure inside the vessels go down. But the blood osmolarity is increasing because you haven't lost whole blood. You've actually just lost water, right? So does that make sense that if you've lost the water part, that the solutes are still there, aren't they? You haven't lost solutes. Does that make sense? So osmolarity is increasing. Then should we feel thirsty? If we're dehydrated, should we get that signal that we're thirsty? We should, so we should get that, and hopefully if you're thirsty, you've got something available to you, you can get that. Angiotensin is going to end up helping to raise blood pressure. It's in response to low blood pressure. So the body is responding to low blood pressure by producing this hormone that will raise it. And also producing ADH, which is also going to help to raise it. These were synergistic hormones. And I promise you that there was a lot of repeat in this chapter. This is all repeat, all good stuff though. At this point, it should be becoming so familiar to you that it's really kind of all the little things are falling into place. Okay, that's how you would hope to be thinking about this. So we can look at these mechanisms, and again, if those of you that are visual learners that like this kind of thing to see if this happens and this next thing will happen, then use these charts to help you with that. Fluid deficiency, I want you to know that the most common shock, what is shock, by the way? And I have a couple people who missed this on last week. What is shock? Dangerously low blood pressure. The most common, dangerously low, meaning that the blood pressure is dropped below a certain level and dropped sometimes so quickly that the body's not going to be able to compensate for it. And the most common is hypovolemic shock. So people should know that. So volume depletion. So you have actually lost whole volume. So the osmolarity is normal, but the volume has actually changed. So hemorrhaging, burns, vomiting, diarrhea. So these can put somebody in volume depletion. Dehydration, you said that you've lost water, but the solutes are the same, so osmolarity is rising with that. So these are some of the situations. What's the most serious effect is going to be neurological dysfunction. And who's the most at risk from the and the neurological dysfunction is going to be the first thing that happens. How many of you seen people who are dehydrated that are exhibiting symptoms of dehydration? Has anybody ever seen? They act like they're what?
Yeah.
Well,
Act like they drunk.
They act drunk, because what's the first thing that's going to be affected is the nervous system. And you know, two words, drunk and crazy, probably we should use in a legitimate setting. But the nervous system is the first affected by this. And what's controlling all the other homeostasis for everything else? The nervous system. So this is a very serious situation. It can go downhill quickly. So it needs to be corrected. And who did we say is the most at risk? Little ones, aren't they? Infants and toddlers are the most at risk for these imbalances. The number one cause of death of kids under 5 years old is dehydration. Now, sure, the dehydration happens because of you know, maybe viral illnesses, high fevers. Because when your temperature's rising, what are you losing? A lot of water, right? So you're losing water when you have a fever. So you should really be making sure that they're rehydrating. So this is just showing you, again, some pictures of how we lose water. Obviously, you know, people think about urinating and defecating, but we lose a lot through our skin. What's our largest organ? Our largest organ is our skin, isn't it? So anyway, I think that if there were two slides in your entire textbook that I'd want to say, if we got rid of the textbook and couldn't have anything else, this would be one of them. And the other one would be that sleep pattern chart where the non-rounded rim, y'all remember that? Where you have to get in a certain pattern, whether it takes you 8 hours to have that pattern or 4 or 12. That's the pattern that you must have for sleep. We know sleep is vital for your immune system, your cognitive ability, so many things, right? So that was the other one. But this to me is This to me gave me chill bumps the first time I looked at it because I did work in pediatric ID for so long. I saw kids come in, it was too late. They'd already gone into neurological deficit because of shock, because of hypovolemic shock. It was too late. There were DOA, you know, and there's nothing we could do about it. But this really gave me chills the first time I saw it. I want y'all to see something about water intake. So fluid volume, we said that, you know, on average, an adult, and we're not talking about pediatrics now, is pediatric medicine a completely different beast from adult medicine? It really is. But adults, 4 to 6 liters of blood volume, so 4 to 6 liters. What this is actually showing you is blood volume, and then it's showing you fluid intake, liters a day, fluid intake. So we know people are most adults are falling somewhere in here. Look at your blood volume though, as long as you have enough liters a day. At least 2. We said the average is about 2.5. As long as you have enough, does your blood volume even change? Does it even change? As long as you have enough, does blood volume change? Look at the chart. Does it change? No, it stays the same. It stays the same because we have so many mechanisms to get rid of excess water. We can pee more often. Oh, let me be professional. We can urinate more often. We are going to be able to defecate more easily because if you're well hydrated, well, things move through your GI tract faster. Yes, if you're well hydrated. Skin, we can lose it through skin. We can lose water through a lot of different areas. So it's the kidneys, though, that are most compensating for it. And your blood volume won't change. Your kidneys are going to be working, and it's going to keep it just so balanced. But look how quickly you can get into trouble. This is what gave me chills the first time I saw it, is because this is pretty darn quickly that someone can actually be hypovolemic and in trouble. You know, they say that if you're feeling thirsty, your body's already suffering because this is just such a quick drop. So anyway, the moral to that story is to stay well hydrated. Now, it doesn't mean that you're to chug things quickly, you know, water, because can you have fluid excess? You absolutely can. But if you're using common sense way to drink, you know, how many of you have heard of these things where you're supposed to drink, I don't know, X or Y amounts of fluid a day, and it's enough to make you feel nauseous, it's so much throughout the day, right? You know, what that's really probably doing is not a whole lot, because your kidneys are clearing it. You get what I'm saying? But you certainly should have enough, because if you're not getting enough, danger happens really, really quickly. You're in a dangerous situation. So y'all don't seem as impressed by that, but maybe you should be. So, okay. Now, excess fluid is also a problem. And when we said edema, I had a lot of, I think this in this class, a lot of people define that as fluid. You didn't say excess fluid, and it really is referring to excess fluid, and that's what it is in a particular location. The most common form of it is going to be systemic edema. So you're going to see some excess fluid in the interstitial spaces of like the extremities and whatnot. So systemic edema. Now you can also have, though, not as common, thank goodness, pleural edema. And what does that mean? Pulmonary edema or pleural edema. What does that mean? Around the what? And you can even have cerebral edema, which means that now you've got excess fluid where? Around the brain. This is the problem when people are doing fluid overload. And if they're doing like chugging, you know, there's people who do those things for I don't know what reason. Sometimes it's competitions where they're chugging either milk or they're chugging, like y'all seen these things, or water, or just chugging anything. It can cause the brain there to be swelling in the brain, and then it's usually minutes. It only takes minutes. So anybody doing that, it's just not a natural thing, and the body can't compensate for it. It can compensate for it if it's over a long time of it during the day, but it can't compensate for rapid increase. Hematomas means bleeding or bruise. We think of hematomas as being a bruise, right? And you don't worry too much about bruises as long as there's not excess bruising. But hematomas, they can be serious enough because that is blood that's lost from the closed vascular system. So if that whole blood gets lost from that vascular system, is that taking blood volume down? Yes. And is it taking blood pressure down? Yes. And so then it can become a problem. And here we said pleural effusions. You can sometimes see liters of fluid being taken off the lungs. If there's fluid around the lungs, can the lungs change shape the way they need to? And what's the only reason that air is moving in and out? Because the difference in the intra-pleural pressure and atmospheric pressure, right? So lungs have to be able to change shape. It makes me want to stand up straighter when I say that. Electrolytes, we said, are going to be a major reason why water is moving because of the osmolarity. When we think about the osmolarity of these body fluids, and we said that these cations like sodium, these are going to be major players, but also the negatively charged ones, chloride, bicarbonate, phosphates. So all of these are going to be players, and we want them to kind of be in normal ranges. Now, I'm not going to ask you to learn the normal ranges, but there are a couple of things I just kind of want you to know about when there's an excess or a depletion of some of these. So we'll take a look at a couple of these. We said our cells are alive, right? It sounds like a partial, but our cells are alive. There's animation, there's work going on. It's constant, 24/7. Every cell has to, sometimes metabolism decreases, so the activity slows down a little bit, but then sometimes signals are given and the activity speeds up. But our cells can never really rest. They're constantly working. One of the things that's constantly working are sodium potassium pumps, which actually use most of the calories that we intake a day, are just these one types of pumps, the sodium potassium pumps. Inside of all of our cells, we have these protein pumps that are pumping sodium against its gradient, keeping it out of the cell. And that is working all the time. This helps to generate heat. This is why we don't slow down and stop moving like cold-blooded creatures do, depending on what the environmental temperature is. What we'll do is just to start to what? Shiver and whatever. So we can warm up if we need to do that with this. When we're looking at sodium homeostasis, hopefully you guys know that aldosterone is that salt-retaining hormone. So we said this salt-retaining hormone, aldosterone, is going to play a role even in the ADH being released. We have ANF that is going to cause the release of sodium. So is this all repeat for you? If it's not, then you need to get it now, okay, and be looking at it now. That's going to be a good thing for you to do. There are others as well. We haven't really talked about estrogen and progesterone yet, but we will. We'll get to the reproductive system. Estrogen is going to help to retain water. Estrogen levels go up by as much as 30 times normal in a pregnancy. So blood volume in a woman who's pregnant near the end of the gestation, blood volume is up by about 30% because of that. So estrogen retaining water during the pregnancy. Progesterone has a diuretic effect. And what do diuretics do? Cause you what? Yeah, lose water. So we have others as well, but those we've already visited. So what would this literally mean if we broke this word down? Are there any such things as big words? No. So hyper, a lot. This means like a lot or excess or above. Doesn't that what hyper means? So this is an excess of sodium in the bloodstream. Now, I'm not going to ask you for learning normal values. Certainly, if you're in a clinical program, you would have to learn normal values and the units that they're reported in. But if you have too much of this, maybe it makes sense to you. There's going to be water retention. Because what do we say follows sodium? Water. We know that's the major one. So hypertension, which is high blood pressure, and edema, which is excess fluid in the tissue spaces. So if there was hyponatremia, which we rarely see, but if there's hyponatremia, maybe that also is something that kind of makes sense when we're looking at this. Why do we rarely see hyponatremia? You can see it, but why do we rarely see it? Because we have salt in everything, and we really do. If you opened a package to eat something, it was just so much salt in whatever you opened, whether it was a can or whether it was a bag or whatever it might have been. There was a lot of salt in it. Now, potassium is the most abundant intra cellular, intracellular. We said this is the one that's inside of our cells. It's the predominant one inside of our cells. So it's determining that intracellular osmolarity is the major player in that. And it's keeping the resting, these sodium potassium pumps that when they're working are keeping the resting potential, membrane potential on the cells. And we talked about this in AMP1, action potentials and resting potentials. And we said when cells membranes are responding to whatever stimuli they're supposed to respond to, we said they're going to be these open gateways. And what's going to pour in to the cell? Sodium, and what pours out in response. And what happens at the membrane? A voltage change, which we call an action potential. Remember that? Okay, so anyway, and we understand that now. Potassium. I do want you all to know that potassium is probably going to be the most dangerous electrolyte in balance. Why do you say that? Because why? It's somewhere here in the notes in a second, but why?
Because your heart.
Yeah, because it can actually lead to arrhythmias. So, and we'll talk about that in just a second, but do understand that all of these electrolytes need to be in balance, but some of them are more dangerous than other ones. And we do know that that potassium is one that we know can be really dangerous. Aldosterone, while it's helping to pull sodium in, it's going to be causing the release or the excretion, I guess I should say, excretion, not really secretion, excretion of potassium. So again, these little charts, if these help you to sort of get it in your heads, I think they're really great. These charts and helping that, if it helps you, then that's great. So hyperkalemia, most dangerous electrolyte imbalance, and hyper means too much, and y'all would want to know this term, hyperkalemia, too much potassium in the bloodstream. And it's going to be kind of a weird situation with this. You're going to have different effects being presented, signs and symptoms of your patients, depending on how quickly potassium is rising. So, and I do think this is something you need to be aware of. So we have trauma cases where people have crush injuries, right? So sometimes it's from falls, sometimes it's from automobile accidents, whatever the situation might be. If there's a crush injury, we said our cells are filled with potassium. So if the appendage or whatever gets crushed, what's being released into the bloodstream? Because the cells are being crushed and lysed. So potassium is, right? So if it happens really, really quickly, then it's going to make the nerve and muscles abnormally excited, but again, leading to arrhythmia. If the rise is slow, it actually does the opposite, but still there's an issue here. So hypokalemia is too little, and again, the nerves and muscle cells are going to be less excitable here, leading to potential arrhythmias as well. So these are some of the situations that hypokalemia, you can see it in. Somebody who's had excess sweating, so again, heat exhaustion, chronic vomiting, diarrhea that can happen because of infectious viral illnesses, food poisonings, but also abuse of laxatives. This can actually cause this as well. So the whole nerve and muscles become less excitable, arrhythmias, decreased reflexes. So people doing head-to-toe assessments and doing that neurological assessment where you are looking at reflexes, pupil responses, grips, the patella reflex, the calcaneal reflex. Those are going to be important head-to-toe assessments to do to see how to maybe even pick up on this. Okay, chloride. Chloride is one of those, because we think about sodium chloride, don't we usually saw it. Chloride is one of those that honestly though, we don't usually see. The homeostasis is usually going to be mostly because of buffering pHs, but we don't usually see the imbalances as playing as big a role. So it's not as dangerous. Let me just say it's not as dangerous as having a potassium imbalance. But anyway, so chloride, we know, having a major effect on pH balance. Calcium, I've told you all why calcium imbalances can take you out of this world today, didn't I? I said it can be because of, and this is related to nerve communication, muscle contraction, and blood clotting issues. So calcium imbalances are serious imbalances, and they really can take you out of this world today. But we have these hormones that we've learned, parathyroid hormone, calcitriol, and calcitonin. Those were just some of the ones we know play a role in calcium homeostasis. Is this all repeat? Is it? Is everybody feeling like this is a good review for hormones? If you're not, then you need to start reviewing the hormones, because we have had all of this. Hypercalcemia. This is, again, when you think about hypercalcemia, you can look that it's going to be decreasing, depressing those reflexes, leading to cardiac arrhythmias. There's an ECG chart that people, if you probably Google this and look at calcium imbalances and look up what the EKG would look like, and it's just diagnostic of this. And so that's usually a quick pickup for people who are in the emergency rooms. They'll know when this is happening, and you would want to correct it. You would want to correct it quickly, but the good news is that you usually can. So they're going to have an IG. Trying to get rid of these. Hypocalcemia, we said, could lead to tetany, and tetany was a sustained muscle contraction, wasn't it? So we said this is going to be happening systemically, and if it happens at the larynx, if there's a spasm at the larynx area, what's going to be cut off? The airway is going to be cut off. So, both of these situations are going to be serious situations for calcium imbalances. So we want to know that. Phosphates to me seems like it should be a more serious problem when there's an imbalance. Because what do we know has phosphates? What kind of molecules do we know that the cell uses have that the cell has that has phosphates? What has phosphates as its strands? Phosphate, sugar, and phosphate.
DNA.
So all the nucleic acids, right? How about ATP and ADP and AMP, right? What was the P part of those? Phosphates, right? So to me, it sort of seemed weird to think that phosphate imbalances weren't as critical as we think of with calcium and potassium. It seems like the body can compensate for these. It does play a role in buffering of pH, so it plays a role in a lot of these things. It certainly plays a role in these secondary enzymes that help with all the messaging that's going on. But the homeostasis, it just seems like it's not, imbalances are just not as critical because the body can usually compensate. So, acid-base balance. What do we know that most fluids, except for urine, most fluids should be in what range? Y'all know this already, don't you? You already know that most fluids should be kind of in this range. You know that acids have a low number on the pH scale and a lot of hydrogen ions. The lower the number on the scale, the more hydrogen ions, right? And bases being the opposite of that. Does anybody have any questions about what pH is? I think I did it a lot in AMP1, and I've done it again in the respiratory system. Does anybody have any questions about pH? Please revisit that, because you might have more questions related to your knowledge of this in this particular chapter. So, buffers or anything that help you to resist a change. Anything that's going to be trying to keep that pH in normal balance is a buffering system. 2 organ systems, respiratory and urinary, but we also said that there are also a lot of chemical buffering systems in the body as well. pH balance is vital. And, you know, just as a reminder of why it's vital, I think we can look at the respiratory. They talk about the respiratory. There's a phosphate buffering system. Renal, we talk about too. But I think that the major thing, this chart's ridiculous. You're not going to see anybody alive here even. Right? So I don't know what they have death down here, but nobody's going to be alive at that. But the major reason, if we think about these hydrogen ions, if somebody's in acidosis, meaning that there's a lot of hydrogen ions outside of the cells here, if there's a bunch of them, their concentration is high, and what would they want to do? Just with no energy needed, what would they be doing? Diffusing into our cells, is that right? So as their concentration is getting higher, pH is dropping, acidosis. Hydrogen ions are moving into our cells. Well, what's already positive inside of our cell? What's the major cation inside of our cell. Potassium, so what's it going to be doing? Moving out of our cells. And what did I tell you is the most dangerous electrolyte imbalance? Potassium. So now potassium's rising. It might be rising slowly, but it's still rising. And so what did we say you're really at risk for? Neurological dysfunction, but also what? Arrhythmias, heart beat problems. So hopefully this kind of makes sense to you that when you're thinking about that, but we also said that when hydrogen ions are off, will that be interfering with your protein structures? What holds proteins in place? What are proteins made of? They're made of amino acids that are hooked up together with peptide bonding between them. But after they've gotten in a chain, they will either coil or fold. And what holds that structure? Hydrogen bonds. Are hydrogen bonds weak or strong? They're really weak. They're the weakest of all bonds. But our protein structures dictate their function. So if pH is really off balance there, it can interfere with the protein structures as well. Alkalosis, you can actually see what's kind of going on with alkalosis, so disorders. You can either have respiratory or metabolic. Y'all look over these, the difference between these. Respiratory acidosis, respiratory alkalosis, and metabolic, both of those two, and take a look at those. So that's this. Was this a lot repeat? Hormones. Did you see all those hormones again? I had promised you that if you didn't get the hormones when we were doing hormones, they were going to come back and bite you. Is anybody feeling bitten? Hopefully not. Hopefully you felt like they were very familiar. But anyway, how do you feel about this chapter? Okay? It's really a great chapter because it revisits those hormones, but it also revisits things in the urinary system. So anyway, I don't think there was anything much new though, was there? Was there anything really, really new in that chapter? I don't really think there was too much. So that should have felt like a very good review. Got any questions before we start with the digestive system? Okay. I don't think anywhere in your textbook did they say this, but I'm not. When we think about the digestive system, obviously the digestive system from your lips to the anal sphincter, right? And anything between that might be contributing into this hollow tube, right? Mouth, starting with the mouth, the esophagus, the stomach, all the way through. About 30 feet is part of this system. It's also referred to as the alimentary canal. And I think I included it in maybe I did in your notes, but I think people see that. It's kind of a little bit old school, but you'll see that, especially in clinical questions about this, the GI tract or the alimentary canal. All right, so what we're going to do is actually, kind of start with the mouth and go all the way through until the anus. So we're going to look at all the organs that make up this organ system, and we're going to take a look at how they function. And do they all need to be functioning so that you can maybe get the nutrients that you need into your system? There's so much that play a role in who we are. What do we know is the major blueprint for who we are? DNA, right? That we inherit. So genetics play a huge role, but genetics will only go so far because we also know that environment is a contributor, a major contributor. So after a point in time, then the environment maybe even takes on more of a thing, because we are what we eat. We have to take in the building blocks that make our cells, right? And we're going to be dependent on what we're putting in our system is going to be related to how our cells can actually function, and all these different cells that make up these different tissues that make up the organ system that make up you, right? So You know, that old wives thing about you are what you eat. We are what we eat. So anyway, we'll take a look at all of these structures. Just because you take in something, does it mean you're going to actually absorb it? You can ingest something without ever it being absorbed. And you know, absolutely every single one of us have swallowed things before that came out 30 feet later unchanged, right? So we understand that that's the case. So when we're thinking about nutrition, we also have to realize that there's a lot that's going to play a role in that. Somebody might actually be taking in all the nutrients that they should be taking in, but are they going to necessarily be healthy? Maybe not, because they really might not be absorbing the way that they're supposed to be absorbing those nutrients, and they're just going through. So ingestion is one thing, and that's certainly something controlled. We make those decisions. Digestion is something that's going to be happening mechanically and chemically. So I would want you all to know that mechanical digestion means, it says it starts in your mouth, but I would actually maybe argue that it starts before then, because you can't just, you know, usually you're cutting up and preparing food right before you put it in your mouth. But anyway, so we'll say that it starts in the mouth though with just chewing. So mechanically breaking down big pieces of meats and whatever into smaller pieces with more surface area, because then the chemical digestion is also starting in the mouth. So this is starting in the mouth. You've got in the saliva, you have these enzymes that are going to start right away breaking down macromolecules to monomer units. What are macromolecules? What did we read on the labels that we're eating? What are the macromolecules we're reading on the labels? How many of you read labels? 2, 3, 4 people. 4 people out of all of us, right? Okay. Some of you just aren't going to admit it because you think it's nerdy. Okay, so what are those things we're reading on labels? What are the macromolecules? Carbohydrates, fats, or lipids, right? Sugars are the carbohydrates, and we break down those, right? So we get carbohydrates, lipids, what else? What are the macro proteins? Y'all know that. So those are what we're looking at. Those are macromolecules. Can you, and you're eating those, but can you absorb them in that form? Macromolecules are called that because they're really big molecules. Do you think those big old molecules can actually cross over anywhere in that tract? Or what is going to have to happen to them? They've got to be broken down to what? The monomer units, or subunits, smaller units, definitely smaller units. They can't go across and be absorbed into your system as big old macromolecules. So the chemical digestion I just talked about has to happen to break down macromolecules into smaller molecules that can be absorbed. And that does start in the mouth. Now, let's say you broke them all down. Does it necessarily mean you're going to absorb them? No, so then absorption has to take place, and that's going to be absorbed into the bloodstream. Some things go directly to the bloodstream, but some things go to lymph first. And I do need you all to know that most absorption is happening in the small intestines. Why would I be able to look at the anatomy here and say that it makes sense that most absorption of nutrients are happening in the small intestines? What about this and that? Does everybody know what the small intestines are first off? Does everybody know that these are the small intestines all in here? This is the large intestines, the colon. People call this the colon, but these are the small. Why does it make sense that most absorption is happening here? Yeah, but is it the surface, because these are the longest part, 22 plus feet are actually of that tract, are these small intestines. And see how convoluted they are? See how convoluted they are? So it means that as stuff is moving through that lumen, which a lumen? The opening in the tube, as it's moving through, it's kind of churning and hitting the microvilli of this one. And there's plenty of time for nutrients to touch the microvilli surfaces of the cells so that absorption can take place. So if I were to ask you where does most absorption occur, what would you say? The small intestines. That makes really good sense that most is occurring here. Now, for absorption to occur, you told me that macromolecules had to have been broken down to monomers or subunits even, so that they could have a chance to be absorbed through. Is that right? Because they're too big otherwise. Did you say that? So if I were to ask you where does most chemical breakdown actually occur, where would you say you think that's occurring? Actually, it's not. It's mostly still occurring in the small intestines. Yeah, so chemicals are being added in the mouth through saliva. They're being added in the stomach, we'll see. And then more are going to be added by the pancreas. Did I tell you all the pancreas is an exocrine organ? What did that mean? It's an exocrine organ, the pancreas. It secretes its products into what? Ducts. Ducts of the pancreas that end up emptying into the small intestines. The liver is going to be releasing bile into the small intestines. And by the time food has gotten to the, according to that, this is not really, we don't call it food anymore, but anyway, by the time it gets to the small intestines and saliva, gastric, whenever you hear gastric, it means stomach, gastric juices, the pancreas, the liver, still secreting. By the time it's getting to the small intestines, everybody's at the party. So all those chemicals are at the party, and they're ready to be breaking down those macromolecules to monomers or subunits that are going to hopefully have a chance to be absorbed during that journey through this very long, convoluted small intestines. Does that make sense? Okay, good. And so anyway, we're going to talk about all of that. And then when we think about these accessory organs, the liver, the gallbladder, the pancreas, salivary glands, teeth, your tongue, that's how your tongue's an important organ. It's an incredibly important organ, not just for taste, for manipulating food to help with that mechanical breaking down. But anyway, so it's going to be an important part. So we're going to talk about all of them. Any questions for me? So understanding that mechanical is going to be this teeth and turning. It is thought that even in America, which is considered to be the envy of most even developed countries in the world, and developing countries, Americans have access to pretty good dental care. But not all Americans, right? And dental care is expensive, isn't it? But it's estimated in this country that at 20 years old, half of the population at 20 years old, half had periodontal disease, beginning of periodontal disease. How many of you work geriatrics, with geriatrics older people? How many of you have seen that when, and I know if you work geriatrics, you have some older people who maybe has dentures, right? Or has some oral issues, problems. How many of you have noticed or worked with geriatrics long enough that you've seen a change in the person's diet due to sores in the mouth or, whatever is happening, the dentures don't fit right? And you can absolutely map their decline. You can see their spiral decline and count the days to when it's over, it's done. It happens quickly in geriatric populations because of not getting the nutrients that they need, and you'll see their decline happen so fast. Have you seen that? So anyway, we will talk about this happening beginning in the mouth. The chemical digestion, we said, is going to be because of enzymes from all of these secretions. Your GI tract is secreting about 7.5 liters of fluids a day, secretions a day. Spit, saliva, more than a liter a day. Stomach juices, more than a liter a day. Pancreatic, more than a liter. Liver. So you're just really pumping things into this 30-foot tract. Now you're also putting in, at least 1.5, 2.5 liters, we said, with food and liquid a day. So you're putting in that much a day, and your system is secreting that much a day just to be moving things along and having the mechanical and chemical digestion occurring that needs to be occurring. Okay? Okay, so this whole moving things along is going to be because of muscular contraction. The want y'all to know a term called peristaltic contractions. There's something happening called peristaltic contractions, and you'll see that word somewhere in here soon. But is it on that one? Whatever. So peristaltic, and then there's something called segmentation that's also happening. But you think about it, you decide what goes in your mouth. I mean, after being a toddler, you decide what goes in your mouth. You decide to chew it, you know, and you decide how many times you're going to chew, and you decide when to swallow, don't you? But after that, it's not really voluntary. It's part of the autonomic nervous system because it's going to enter into this muscular, smooth muscle surrounded tract until it gets to this end, and then all of a sudden you've got voluntary control again of getting rid of what couldn't be digested. But what's happening all between there is going to be a type of muscular contraction along that tube, and let's think of it as a tube. It's called peristaltic, which is coordinated contractions. So it means that, like up here, there's going to be this contraction of the esophagus and an immediate relaxation of the muscle right below it, so that when this contracts, what was in here goes to the one below it that's receiving it. Then this contracts, sending all in one direction. Now that takes incredible coordination, doesn't it? And it's happening by your nervous system, your autonomic nervous system. You're not having to think about it, thank goodness, right? Now, can people's nervous system, can people's muscular tubes start to not work, right? You've heard people who have, well, maybe you haven't heard of this, but their esophagus, the esophagus, which is a muscular tube, can get stretched out. I heard a GI doc call it one time a tortured esophagus because a person kept having reflux. Do y'all know what reflux means? You should know what GERD stands for. GERD stands for gastroesophageal reflux disorder. Sometimes you'll see disease, sometimes disorder for that D. So gastroesophageal reflux disorder. Should things come backwards in the system? Or should things just be going in one direction? Right? We've all had things come backward, right? We'll talk about vomiting in just another day. But that's not a good thing. You know as soon as you do it that that's just wrong. My great nephew had his first vomiting episode. He's going to be 2 in June. But my sister called me. She was like, "Oh my God, Noah vomited," and he was horrified. And it made me think about one of my own kids that did that, and I'll just never forget the look on his face. Like he thought I did it to him, you know. Like, so, but anyway, I didn't. It was the virus or something. But anyway, things shouldn't go backwards. They should be going down one direction. So anyway, but people who have GERD have this constant reflux where from the stomach, it's coming back up into the esophagus. And sometimes they have a really hard time emptying from the esophagus to the stomach. What is a sphincter, guys? Tell me what a sphincter is. It's a round muscle that is going to allow for things to move. It's going to control organ volume. So we talked about internal and external sphincters from your bladder to the outside, right, at your urethras, didn't we? And those sphincters are allowing the release of urine. That was one particular sphincter, right? Or not. Is that right? So you also have sphincters here right at the top of the stomach at the bottom of the esophagus. So as liquid and food moves through your esophagus, this sphincter is supposed to relax and allow liquid and food to enter into the stomach. What happens when it's not getting that signal to do that, though? Can things back up in the esophagus? They really can. And even stomach acid, and we'll talk about why the stomach acid is acidic in a bit, but this can come back up. And so this esophagus can get stretched out. How many of you know people who can't eat unless they're drinking water at the same time? Nobody? Well, good. A lot of you don't. But a couple of you said. If that's really the case, it's probably that their esophagus has already gotten a little bit stretched out for whatever reasons, that it hasn't emptied well into the stomach. So you guys, we know there's behavioral things that can lead to GERD. What are some of the behavioral things that can lead to GERD? Gastroesophageal reflux disease, which sometimes people call this reflux what? Indigestion. What are some things that can lead to it? Well, certain types of foods can irritate certain people. That's really true. Alcohol, somebody said alcohol. Exactly. So not allowing the stomach to empty, it can take for some people as much as 4 hours. So eating right before you lay down, is that going to contribute? That can contribute, right? Overfilling the stomach, that could be an issue, right? Eating too fast because you're too hungry and then overfilling, right? That can, all these things, these kind of things can lead to it. Can lead to maybe the beginning, and then over time chronically really absolutely lead to people having trouble with this. But anyway, so we're going to take a look at all of this. We'll go ahead and start with, oh, I didn't know we're going to start with that, but okay. If we did a transverse section, I told you that this is a muscular tube. And so you have this inner lining of this tract, and this inner lining, then you have an outer lining, but there's this middle tube. And does there have to be blood supply to every one of these tissues? Of course there does. So there's going to be blood supply. The peritoneum, I want you all to know this peritoneum area is going to be kind of isolating. When we think about this, there's this peritoneal lining that's kind of isolating these structures and compartmentalizing them. So this is, if you've ever heard of peritonitis, what is that going to be inflammation of? Peritoneum, right? But please keep in mind, even though I probably won't even mention it again after this, but keep in mind that this tract, 30 feet or so tract, all of these tissues have to have blood supply. And all these tissues need to be stable as far as their location. When we dissect rats, which I guess will be maybe next week, that we dissect those rats, you're going to actually see this isolation in the abdominal cavity of these structures. So we said there is a dome-shaped muscle right here separating the thoracic from the abdominal. What was that muscle? The diaphragm. And then we've got this peritoneal covering here, and all of these structures have to have blood supply. When we think about this omentum, this is going to be almost like a little fatty apron, it's kind of called, but there's this blood supply. So when people have injuries to this region, when blood supply gets cut off to these tissues, can they lose whole sections of their intestines? They really can. And actually, if it's devastating enough, obviously it would be a life-threatening kind of event if this was devastating enough to them. In this particular picture, you've seen most of the small intestines removed with just a part of the lower intestine still in place. But all this blood supply, this mesocolon, mesentery, all of this has to be maintained. So sometimes when people have abdominal surgeries for whatever reason, laparoscopic even surgery, where they even take little incisions and go in to remove gallbladders or to do whatever they're doing. When people have had injuries, it can cause scarring. And with scarring that are at these sites, can the scars actually end up blocking blood supply? Can they? Yeah. And so sometimes people have blockages because of that. And it can be serious, and it can lead to gangrene. And then if it leads to gangrene, that's an emergency situation where you have to go in and remove those dead sections, right? Okay, so let's don't forget that any of these structures we're about to talk about has to have this constant blood supply to all of them. So we'll start with the mouth. How many are doing dental hygiene? I've got a couple of people doing that. So you guys are going to want to, right now, y'all are going to want to learn all the teeth in this section. But the rest of you, I'm not going to test you all on it, but you guys should learn those now, right? The names of these. But when we look at this mouth or oral cavity, we said that this is our first one. Really, we think about the first place that mechanical and chemical digestion is actually occurring. So good oral hygiene is vital, and health is vital for nutrition to actually happen, because this is the start, this is the beginning. So we know that, you're not gonna have to label any of this. I'm gonna give you the structures that you need to label, but y'all know what the palatine tonsils are. You know that we have all these tonsils here because our mouth is actually filled with a lot of normal flora, isn't it? Normal bacteria that are supposed to be present that actually are healthy to be there because they're protecting us from potential pathogens. Tonsils are protected. They have these crypts where there are going to be these nodules that have a lot of white blood cells that are going to help to trap and catch and clear out any potential pathogens that may be present. We have the pharyngeal, the lingual, and the palatine tonsils. This uvula, what's the function of the uvula? Did y'all tell me? Some people call that the dangler. What is the function? It closes your nasopharynx. What does somebody say? It closes the nasopharynx so that food and liquid don't go up through you to the nasopharynx through your nose because it doesn't feel good if it does. So, so we know about that, and then we've got these frenulums. Some people, this is so low that it causes the teeth to be separated, right? Some people just from aesthetic reasons think that's whatever. This lingual frenulum is rooting the tongue to the base of the mouth. If this is too close to the tip of the tongue, people are said to be tongue-tied. I'm tongue-tied if anybody wants to see what that looks like. Now they usually they check babies early for this, because if a baby is if it's severe enough, it's going to interfere with them suckling. If it's not severe enough, then it doesn't interfere with them growing and progressing, but it can definitely interfere with speech. So now they look at babies as part of their examination, and they usually will clip it. Does anybody know? Did you have yours clipped?
No, my sister did.
Yeah.
It was a nightmare because
She remembers it?
No. I remember.
Oh.
Because when she was eating one night, she started bleeding and bleeding and bleeding, and it wouldn't stop. It finally stopped, but it didn't look like it was.
So they had clipped it. And then it started to bleed after they clipped it.
Well, I'm sure it was when they clipped it in the office. We came
Then
home.
it started bleeding again.
Yeah, and then she also had the top of her lip clip too.
Mm-hmm. It's because really you can't. But how old was she?
It had been. She wasn't a year yet.
Yeah, that's sweet. He remembers how scary it was. Mouth wounds can look horrible. Why? I mean, it can look like more blood than it really is. Not that you're not supposed to be concerned if somebody's bleeding like that from the mouth, but they can look horrific because it's mixing with all the saliva and stuff. So it can look sometimes a lot worse than it is. That's sweet that you're concerned. So it's really to anchor these things, but if they're really too close, then the babies can't latch on. And like I said, it can also interfere with the manipulation of food, but it can also interfere with speech. So it took me a long time, and I still have to concentrate on saying some sounds because mine never got cut. You wouldn't want to cut it after they're a certain age, because then they have to learn how to speak all again, for some kids. Anyway, it's really common actually for the tongue. They don't worry as much about the superior labial, because labia just means lips, right? Y'all know labia means lips. So if you didn't, you should know that. Labia means lips. Okay, so they don't, unless they can't latch on. And if it's so tight that they can't latch on, then they will definitely notice it right away. All right, so looking at the teeth though, baby teeth, this is what most people have. So most babies have 20 teeth. This is genetic. Some people are lacking incisors. Do y'all know people who are born with incisors, but never developed incisors? No? Okay, well, but this is genetic. But most babies have 20 teeth, and then most adults are going to end up having 32 teeth. This is sort of a sad thing, because obviously it was a child that died here. And this child, if you look at this skull, you can see a baby's skull. It's just full, the maxillary bone and even the mandible is full of blood. They're just full of teeth, aren't they? So it's important that the baby teeth stay as long as possible because they are actually holding the place for these permanent teeth that are developing and that will follow along. So we know that sometimes babies' teeth are not, are kind of discounted because how many of you have heard that people say, oh, that's just their baby teeth, it's okay if we lose them. No, it's really not. So most of the time, teeth are going to start to come in at least by a year old. This saying sort of goes that the later that they start breaking teeth, the longer that they'll keep their baby teeth, which is actually a good sign. Some babies are born with some teeth. Has anyone known anybody? No, I should say. It's just different. That's an anomaly. It's just different. That can happen. Has anybody ever seen that? No? Okay, so it's kind of rare. But anyway, most are going to be, 8, 9 months. Some as early as 2, 4 months are going to be developed, or going to be getting baby teeth. And then just being really careful. What do you to never give babies, little kids? Ice?
Not a whole lot.
Yeah, so you're not supposed to give, babies up to 6 months only need breast milk. No water, nothing else, just breast milk on very regular intervals because they cannot maintain their glucose homeostasis. So on very regular intervals, it's all they need. Now, if you're doing formula, there can be some other guidelines, but usually they don't need any other foods until about 6 months. Then you start introducing foods, don't you? Start introducing foods at very prescribed times, slowly, so that they won't develop food allergies, which we'll talk about in a minute. I mean, in a little while, not today, I'm not let y'all go. But anyway, so that's what you do, but you never give juices or sugars, until after they're maybe if they're toddlering, but you really don't give sugary treats, right? And you're never supposed to put bottles, let them go to bed with bottles, right? Because that's really bad. And anyway, how many of you seen little kids with soft drinks, little toddlers with soft drinks? A lot, right? Yeah. So anyway, but that can really do terrible things to the baby teeth. All right, so the tooth structure we'll talk about when we come back. Y'all, the kidneys, I have kidneys that for y'all to look at. I like kidneys myself. I think I do. But anyway, no, I have kidneys for y'all to look at, and I have models. But let's look at one Thursday. Wednesday, Wednesday, okay? I'm letting go. Good. Well, do you want a study guide discussion thing for today? Yeah, Sarah. No, not you. Just the vessel. This is take a break. Do y'all want the study guide discussion thing? All right, well, I'm doing it then. Good for you. Good for you.